Chapter 35. Modern psychiatry pathologizes illness and medicalizes the notion of recovery. If you take this pill and that pill, hopefully that will be the cure and you'll get better. In truth, it is paradoxically both more simple and more complicated than this. Compliance with medication does not equal recovery. Medications alone cannot create a life. We have to do this ourselves. It begins with the basics, having access to a roof over one's head, food on the table, the company, support and compassion of others, warmth and light. These are the essential ingredients for building a functioning, stable human life. A person is much more likely to take medication and take it as prescribed if other parts of their lives are settled and provided for. An unwell person with no home, always on the move, is going to find it hard to cooperate in a treatment plan. Generally speaking, if a person has no address, they won't receive appointment cards and are less likely to have regular contact with a GP or psychiatrist. They are less likely to pick up prescriptions and less likely to have money to pay for any of this. As illustrated earlier in the revolving door scenario, attention is only drawn to this person when a crisis occurs and the intervention of police and/or community mental health teams sees them admitted to hospital in an acutely unwell state. Stabilised whilst in hospital, the cycle begins again when they are discharged back to no fixed abode. From the platform afforded by the fulfilment of basic human needs, a person can move on more readily to identifying and meeting the next layer of needs, such as returning to study or employment, forging social connections and making friends, and identifying and involving oneself with interests and pastimes. These are fairly ordinary components of a life, and healthy people take them for granted. Yet many people in the mental health system no longer have such things in their lives. Mental illness, the treatments and the stigma attached to the sufferer have a way of ravaging the person from the inside out, so that by the time they wind up as inpatients in a mental hospital, there often isn't much of a functioning life left to salvage. If you want to do things differently and are ready to take back some of the control over your health and your life, find out what you can about your diagnosis and treatment options. Being armed with reason and knowledge is a more powerful position to be in than being solely at the mercy of what a doctor might or might not choose to tell you. It's worth doing some homework. After all, it is you that has to live with the decisions that are made about you and your life. Often people being treated in the mental health system feel daunted by the impersonal manner of the medical staff and feel unable to ask questions and engage in two-way discussion about their treatment. The detached persona of the psychiatric health practitioner is intentional. It is ostensibly to protect both the practitioner and the patient from the consequences of either party becoming too involved. On the part of the practitioner, this behaviour would be viewed as unprofessional, inappropriate and risky. To what extent is this perhaps a faulty assumption? The well-intentioned, or sometimes habitual, professional detachment manifests itself as an aloofness and creates an impenetrable power differential which patients perceive as maintaining an us and them culture in the relationship. The level of detachment is controlled by the practitioner and is part of a power dynamic which is antipathy to any concept of recovery as an active partnership. Power struggles have no place in psychiatric care or in the provision of physical health care to people with a psychiatric diagnosis. The essence of a therapeutic process lies in the negotiation. An acceptable plan or treatment solution is one which has been arrived at with the consent and approval of both parties. Otherwise, it is coercion. People often have very sound reasons for refusing treatments or behaving in ways deemed non-compliant, even if they are unable to communicate this clearly. Everyone deserves the respect of being heard and of having their concerns taken seriously, both doctor and patient. Sometimes practice considered professional is a mindset or a set of actions underpinned by an unquestioning and rigid application of an ethical concept. It leaves little room for a flexibility which is surely more apt in such a human vocation. As a result, the possibilities of more effective ways of carrying out a practitioner-patient relationship remain largely unexplored in psychiatric healthcare. It is not unusual to observe staff doing their best to adhere to a very literal interpretation of what they consider to be not getting too involved, at the expense of forming humane and caring connections. Is it possible that a skilled communicator could navigate the risks of a genuinely therapeutic relationship, having the ability to both protect oneself and the client, and at the same time creating authentic connections in a healing alliance? The answer, thankfully, is yes, and I have experienced such practice when mainly nurses have allowed a more interpersonal tone into their work. I find a refreshing example of this when I reflect back on the day whilst in Rata, when the nurse had sought to offer me comfort by disclosing her own past. It meant a lot that this person was willing to venture into an empathy and identification that bypassed the more common straitjacketed interpretations of professional boundaries. In her ability to make a compassionate human connection, her method was surely closer to the true essence of nursing kaupapa, that of the caring profession. Another common barrier to creating and sustaining meaningful therapeutic relationships is a perceived lack of time by staff on busy wards. But the only reason staff are there is because there are patients, and surely that investment of time at an inpatient level is recouped in the reduction of time spent on revolving door admissions, the yardstick of a job well done. Being listened to, understood, and cared about are the modest dynamics implicit in a healing relationship. Psychiatry and its associated disciplines can drift far from this simplicity in the drive to contain and make sense of the complexities of a dysfunctional mind. In venturing beyond the divide of detachment and time constraints, warm and compassionate interactions, whether with staff, other patients, friends or family, are the stuff that recoveries are made from. They provide both the incentive and the nourishment to remain connected to the land of the living, literally lifelines. But I hear you ask, how can these healing partnerships function when the patient is in the grip of an acute psychiatric episode? A possible answer lies in an important recent development in New Zealand, the introduction of Advance Directives. These living wills have been brought into practice by the service user community in an effort to both improve the rights and minimise coercion of people being treated in the mental health system. An advance direction, an advance directive, enables a competent person to make decisions about future treatment, anticipating a time when they may become incompetent to make such decisions. Unquote. The content of an advance directive includes your preferred medication and treatment options and stipulates specifically treatments that you refuse consent to unless ordered under the Mental Health Compulsory Assessment and Treatment Act 1992. It is advised that these requests are signed by a witness as well as yourself, someone who can testify that you are of competent mind when the directive is drawn up. An unambiguous and informed advance refusal of treatment by a competent adult is legally binding in New Zealand law. It can, however, be ignored or overridden by a doctor if 1. The advance directive does not apply to the particular situation that arises, 2. The advance directive is not clear, or 3. If the Mental Health Compulsory Assessment and Treatment Act 1992 is used to override a person's intentions regarding treatment. Nevertheless, a detained patient's advance directives about their treatment preferences should always be considered with respect by mental health professionals, unquote. It is a good idea to think about and draw up an advance directive while you are in a good space and are capable of understanding treatment information and making considered choices. It is advisable that you explain why you refuse certain treatments, and this explanation is part of your being deemed competent to make such decisions. There has as yet been no precedent-setting case involving a challenge to an advance directive of a mental health patient in a court of law in New Zealand. However, legal advice on this matter is that health professionals should, quote, ignore advance directives at their peril, unquote. So it is well worth writing one and getting a copy put on file with your mental health care provider. Service user organisations may have a template for you to use and can help you to access legal advice should you require it. It can be useful to have an advocate present in meetings regarding treatment, especially one who is versed in your preferences and can support you to get the treatment you choose and consent to. Psychiatrists are becoming more accepting of the need for patient partnership and participation. Whilst it can feel like slow progress, the old ways of practice are beginning to change for the better.